Good day, everyone. I'm delighted to take part today in the Nursing the Future Speakers series. It's a great pleasure to work with Judy and the team to bring this series to you. I'm Mike Villeneuve. I'm the CEO of the Canadian Nurses Association, and as I say, just absolutely delighted to take part in this work. We helped to bring this to life with all of Judy's leadership. We were really just background support through the summer, I suppose the late spring and summer of 2020 as the COVID pandemic continued to unfold. And our hope at the Canadian Nurses Association was to help to sort of metaphorically embrace the generation of nurses of all categories, all regulated categories, who would graduate during this very difficult time, and try to help put some supports in place to build your success. So I'm thrilled to be part of this. I come to you from Eastern Ontario, as it's now called, but which is unceded Anishinaabe and Algonquin territory, where I have the great privilege to move about the world and lead my life, as our elder Aline Laflamme says. And this is gorgeous view, which I always say is my backyard, is in fact behind my house, but is the part of the gigantic farm properties of my neighbors next door, but gives you some sense of the unbelievable beauty of the farmland in which we live in Eastern Ontario. This, as I don't need to tell you, is the year of the nurse and midwife, and as I've been saying, any chance I had, what a year of the nurse and midwife it has turned out to be, particularly challenging for nurses. And despite our many planned celebrations and acknowledgments of nursing through this year, things have gone in a very different direction. I suspect many of you, whether you're students or you're a brand new graduate or a long-serving nurse in any of the categories, will have been pulled in many different directions this year. Some of them as dramatic as people being moved from surgical units out of their employer settings to long-term care, for example, to support those areas, and indeed the a number of sicknesses of nurses, and the death of one nurse in Canada and more than 1,100 around the world has jarred us in nursing, to say the least, and shaped everything about our intended marking of what nursing is and could be. And we hope now that the Year of the Nurse will continue into another year or more, waiting for the United Nations decision on that, so that we can indeed celebrate nursing and nurses as we come out the other side of this at some point. I want to tell you quickly about the CNA, and I'll be very brief so that you have some understanding, if you don't know us, of what we do. So, different from the union, which does negotiations and agreements around things like salaries and sick time and all the benefits you get, your workplace health and that sort of thing. And they do much more, but that's a prime business of unions is to excuse me, think about the individual and their rights and their employment. Different from regulators, where you get your license to practice. And I think of them as the police force, and some nurses sometimes say, well, the regulator doesn't do anything for me. They don't do anything. The regulator isn't there to do anything for you, right? So they're watching you. And I don't mean that in any pejorative way. They are there to protect the public. And if you're lucky, then the regulator never will have anything to do with you. You'll just pay your money every year and be safe and show that you've learned and so on. And that's what their job is. And we're the third pillar of that stool, in a sense, the professional association, which represents the professional voice of nursing. How do we move the profession forward? What do we do to impact health and health systems? How do we build strong leadership? Excuse me. And how do we serve the public interest? So we do all those other pieces that are different from the other two groups. I want to talk about a few trends that are on CNA's radar all the time, and then I want to talk about you as new graduates and people welcoming new graduates, and some of the, I guess, issue you a couple of challenges in how you can, how I think you're going to practice, and how you can help us to make that good, make that practice vibrant and strong, and help shape health systems. I won't need to tell you, because it's around us all the time, that the whole world is aging. And Canada is very quickly moving toward becoming one of the super aging nations, which is where more than 20% of the population is over the age of 65. This matters particularly to you coming into practice now, because outside of the small number of nurses who work in labor and delivery, pediatric hospitals, and those who work in Emerge and primary care in primary care offices, the vast, vast majority of nurses will never put their hands on a child or a woman in labor. And almost all of your work, our work, is with older people, whether it's in a critical care unit, a surgical unit, a dialysis unit, palliative care. And all of that, is, I don't need to tell you, is because older people tend to be the people who are more fragile and frail, get sick, and younger people don't. So even through much of my career in neurosurgery, in the clinical part of my career, a great number of the patients were older folks. I was in a bit of a blip because I worked in the trauma unit, and trauma patients do tend to be younger. So if you work there, you'd see some of those younger people. But in the main, your work and your career lying ahead is going to be around how you care for aging Canadians. We're at a point now where, for the first time in our history, there's more people over the age of 65 than under the age of 15. Never seen this in history before. Typically, there's a lot of young people, especially since the advent of antibiotics and immunization earlier in the last century. So lots and lots and lots of young people lived where they used to die. And typical population curves show a lot of people at the bottom end of the younger ages and fewer at the top. And suddenly we're having a flip of that, where there's a great pile of old people in this country and many, many fewer at the bottom end. And that has all sorts of ramifications for taxes, who's going to pay for care, who's going to pay for all the airports and the roads and education and so on, if there's a huge chunk of the population that's now at the older end and not contributing in the same way in terms of productivity and taxes into society, for example. We anticipate that the group of people over the age of 75 will double over the next 20 years, roughly. And so think about your own career. You're going to be those people delivering that care over 20 years, as more and more and more of the population you serve will get older and older. And to give it some context, we often talk about the baby boom born after 1945 or around 1945 to 1960. And I'm the tail end of the baby boom at 61. Most of the people in the baby boom now, not most, but many, are into their mid and late 70s. So that gigantic wave isn't some theory in the future. It's right now, because they're going to start to get frailer. They're going to have dementia. They're going to need a lot of care. And we are in many ways quite unprepared to deliver it. The amount of chronic disease that's growing around the world, that's a huge burden to health systems. I'm going to go quickly through these, so I'm just going to make general comments because I know we don't have a ton of time. Oddly, we're also facing communicable disease spread, which we thought we had under control, and setting not SARS, COVID-19 aside for a minute. One of the issues here is the sudden resistance to vaccines, for example. So we fought for centuries to be able to live longer lives healthfully, and developed very, very effective immunization programs against mumps and measles and rubella and on, and polio, all of it. And suddenly now, and in what is the most educated generation of people in history, we have people who say, well, I'm not going to do that. I don't believe it works, or I believe it causes some other problem. People somehow have been convinced that a dead vaccine that makes them feel a little bit ill sometimes for a day after they have it, as their body builds immunity against it, means that they've somehow caught a bit of the disease. So that's one of the issues. There's the long-standing issue that it causes autism, for example, or they can cause autism. Nonsense, right? It's not true, but people still believe some of that. So now we're fighting not just non-communicable diseases, but well into the 21st century, back to 150 years ago, communicable disease. In our own country, access to long-term care is a challenge, sometimes when it's needed, and I mean institutional long-term care and to home care. And neither one of them are covered in most provinces and territories under Medicare, so involve a lot of personal payment, which becomes a huge barrier to people in their older age who may or may not have saved money, may or may not have pensions, and don't have access to publicly funded care. And a companion issue is that most people, 75% or more, would benefit from good palliative and end of life care, but 75% or more in our country never get it. So a completely opposite mismatch of what is needed with what is delivered. Final trend I want to talk about is safety and in healthcare. Now, some of the high rates we see of safety concerns is because we're actually measuring it and identifying it. It's like COVID, the more you test, the more you'll find. So some of it is that. But we also have some really serious concerns about the number of really serious safety incidents going on in the healthcare system. So serious, actually, that um, when you measure who's in hospital beds on any given day, more than 1,600 of the beds are taken up by people who don't need to be there, but are there only because of something bad we did to them in the course of their care. Wrong medication or wrong route. Left something inside them in the operating room. They fell on the floor. We dropped them. These sorts of things. Terrible. Some of them very, very serious, and many resulting in deaths. So if you think about a healthcare system that's clamoring to get people into beds and get them their knee surgeries and heart surgeries and eye surgeries and whatever they need in hospitals, we have thousands of people in the beds in alternate level of care who are older folks typically, who don't need to be there but have nowhere else to go. So they're called ALC, alternate level of care, and they're sitting in hospital beds. Another 1,600 that we heard. So think about the number on an average day in this country of beds that we could free up if we had different ways of looking at healthcare systems and how to manage all those people. And that's the help we need from you, the new generation coming into the healthcare system. You will have ideas we haven't thought of, and we need to hear them. Final comment, I suppose, in the area of what we're funding is around the social and economic and environmental and indigenous determinants of health, because we know that about 75% or 80% of our health comes from factors that have nothing to do with what you will spend your careers doing, which is delivering formal health care. Some of you will become policy people working in determinants of health, and that's great, but many, many nurses quite rightly choose a career where they're delivering care. And so we have to ask ourselves, what is the end game of funding a system where 70% of the funding goes to hospitals, doctors, drugs, and other institutional wall kinds of facilities? 70%. When we know that more than 70% of health comes from things that have nothing to do with that, right? So in a sense, there's a really great mismatch in our country. Health systems are well set up, as I just mentioned, where we spend 70% of the money to deliver acute care, treatment, rescue, and cure, right? It's exactly what we needed in 1975 in a young, burgeoning population in its first generation of Medicare, a growing young country. But now we're in a world of old people. I include me. I don't mean anything disparaging when I say old people. Old people are old people who need management of chronic diseases, support for healthy aging, and really great palliative and end-of-life care. it's almost, if you picture, a scale, the scales, one side and the other side tipping, or a seesaw. We've tipped it all the way to one side, and almost need to recast the whole healthcare system. In the end, politicians make the decisions, and we need to help inform them, because in the end, as this is a quote from a female family doc in Toronto, and I apologize, I'm forgetting her name, wonderful woman from Women's College. Politics is the most important determinant of health. And it doesn't matter what nurses say and doctors say and so on. Look at the South right now. Look at the absolute complete nightmare of COVID in the United States, because it's politicized healthcare and put the running of a gigantic emergency in the hands of a person who doesn't have the ability to understand what it actually is, and taken it away from doctors and nurses and health scientists, and completely politicized it. Terribly, terribly damaging and threatening. And we need to, as nurses, make sure that we are at the table when decisions are made. They may not go in our favor, but at least we'll know that we informed the decision the best we could. To summarize where we're at where are we? October of 2020, the Canadian Nurses Association set down these priorities and recommendations for the speech from the throne last month, recommending that the federal government pay very close attention, to ensuring pandemic emergency preparedness, which includes all the issues around testing and personal protective equipment, invest in virtual care to support vulnerable groups, improve supports for the aging population, strengthen the national anti-racism strategy, improve access to primary care, which has been dramatically improved through virtual care during the COVID pandemic, so they are linked. But people need broadband, for example, and governments could invest in that. Implement the pharmacare program and increase mental health funding for healthcare professionals, including nurses. So you're going to hear about these issues over the coming year as you're in practice, if you're connecting with the Canadian Nurses Association, or you may see some of our materials come your way and asking for you to engage with us in helping move it forward. Okay, so we're going to need to do a few things differently, or we're going to just keep banging our heads against the proverbial wall and not moving things forward. So let me quickly talk to some of those. We know that interprofessional collaboration has great benefits. So people working in teams where there isn't always one leader all the time, and people move in and out and blur their roles in a sense, have great benefits for patients and users of systems around wait times, healthy workplaces, safety, and so on. And getting to good interprofessional care means we as nurses in all the categories have to understand intraprofessional relationships. What is it that the RN, the LPN, the registered psychiatric nurse, the nurse practitioner, and so on, even at the other end of the scale, support workers on one side and physicians and so on the other, what are they all doing, and what could they do, and what are our roles in the inter and the intra-professional practice? I'm not going to read all these slides because you'll have them, but we know from talking with students that certainly in the RN and LPN programs, they recognize a lot of role ambiguity, hierarchies, turf, and so on really do hinder really safe, good patient care, and the faculties recognize it too. So we know we have an issue here that we need to sort out going forward. Certainly, we know from observation, but in some of the work that Dr. Almost did for us over the last year, those old power structures, and again, what you heard from students, lack of role clarity, have really been entrenched over many, many years. And we need to really start to unpack some of that and work together in a much more strategic way. Public expects it, so that we can deliver really good care going forward. We know that a lot of the models of care work very well, but there are many that don't, and people aren't satisfied, and the safety is a problem. So what is our role as a large 440,000 profession of nurses, what is our role in fixing that? A key question for all of us, and I think for all of you coming into care settings, and one I would urge you to not lose, is this one: is what you're doing relevant, and is it making a difference in the life of the patient? You can get very quickly into the sort of machine of a hospital, for example, where you're just grinding out 12 hours of running, doing tasks. And when you step back and say, what do the patient actually want? What do they actually need? Sometimes there's a mismatch there between what we're all doing and what patients really expect of us to do versus what the institution employs us to do. They can be quite different things. We need courageous, young, new graduates, along with an army that we have already of people working in the profession, to challenge some of these things. When you look at the workforce we have around us, starting with care support workers, there's about 350,000. You can see the numbers here. We have about 440,000 nurses, another 350,000 in support roles, roughly 91,000 physicians. That's a lot of people. Now there's tens of thousands more: social work, OT, PT, dental, tons more. But if we just look at this group where the scopes are so overlapped, the circles aren't exactly correct. I mean, the MD role doesn't overlap that much with the care support worker. So if you had a great creative designer, you could design the circles all in the right size. But I'm sure you get the message, or I hope you get the message. Much of what we do overlaps, and there are parts where almost any of us could do the work of any given task. So we need to figure out, and again, we're going to need your help because we're finally having these conversations. What are the unique roles that only, let's say, the LPN can do and only the nurse practitioner can do? And then what are the ones where everybody who's on a team could pick up and do that piece? And often they relate to increasing complexity, increasing urgency, and uh, in decreasing predictability. So as care is more complex, more urgent, and less predictable, you tend to want your most advanced education, critical thinking people doing that. That's one of the guides. We know that nurses have to help deliver really on 5 promises, which is that we owe to people the right care, the right delivered by the right provider, at the right time and in the right place, and in a cost that systems can bear. We know then that many things that used to be done only by a registered nurse not only can be done perfectly safely by a licensed practical nurse, but are often done by patients themselves. There are pieces of care, I can assure you, in my 40 years in healthcare, 42 now, that used to be done behind walls in chemotherapy units, that no one could ever get in there or see any of that, or people would die. Now patients do them in their living rooms. So we need to understand the shifting ground around us and who can deliver, who should deliver safely any one element of care. We in nursing are being called to optimize our scope of practice. You are graduating whatever programs you are in. You are the best educated generation of nurses in Canadian history, and in many ways the best in the world. And often nurses go into practice settings, I'm just going to be frank here, and we can debate it sometime in person, where the work that they do looks like it's from 30 years ago. The scope hasn't changed very much. The equipment has changed. It's much fancier, but the scope hasn't changed very much. The public's asking us, you nurses with all your new bright education, we need you to do some different things. We need prescribing. We need you to admit maybe into hospitals. We need you to run nursing homes and so on. That's the kind of thing I'm talking about, and that's going to really be a confrontation in your own careers. We know that no one owns competency, so the notion that only one person can do this task is nonsense. We've lived with that for far too long and built gigantic silos that says only the nurse can give an intramuscular injection. Only the doctor can diagnose a sore throat, for example. This is not going to be the hallmark of the 21st century. The 21st century is going to be, this is the series of competencies that this population needs. It could be a unit on a hospital, it could be a town, could be a classroom. Who can deliver the competencies safely, or what mix can deliver them? We're going to not be working anymore. We cannot work anymore in rigid hierarchical silos. A message you can take away from this talk is one that came out of systematic review we did for the National Expert Commission back in 2011 and 2012, and it is that nurse-led models of care are as clinically effective or more effective, meaning they're safe and effective, than traditional models, typically led by a physician. They are as satisfying or more satisfying to the patients, and they're delivered for the same or less cost. So this means you can safely deploy nurses when they're properly educated, all that sort of stuff, properly credentialed, to lead models of care, even in independent, freestanding clinics like they do in the NHS, the National Health Service in the United Kingdom, perfectly safely. What we haven't done is get past that. Politics is the most important determinant of health, right? We haven't really, as a society, moved past the notion that the physician, and they're great, this is not anti-doc, but that the physician has to see every single patient. Not true. I just want to say a couple of things about long-term care in Canada, because we've been through a very tough time in COVID. And my challenge to you at the beginning was to imagine your careers around older folks. And long-term care, I think we need to flip our heads a little bit and and challenge ourselves that long-term care is not all nursing homes. What Canadians need is care in the long term. 93% of them will never go into a nursing home, but they need long-term care, right? They need it in their homes, in their church basements, in daycare not daycare, but centers where seniors can go for a day to have socialization, maybe get their blood pressure checked, have a meal, and so on. You know what I mean. Primary care clinics, and palliative care, and so on. But we've heard a lot of them, and in some cases almost abandoned them in the recent COVID pandemic, where 80% of the deaths happened in long-term care, where only 20% of the cases were long-term. So that's problematic, and we need to repair that, and we need your help. I'm going to move past this quickly, just by way of wrapping up, to say the conference board says we need somewhere around 200,000 more beds over the coming 20 years or 30 years to manage the baby boom. And that is never, ever, ever going to happen. So what are we going to do to manage Mike Villeneuve, who's now 61, when he needs an increasing amount of care as he gets into his 70s and hopefully 80s and on, where we cannot possibly house, or worse, warehouse all those people in institutional settings? What is that model going to be? And what are you, as our new generation coming into care systems, how can you imagine restructuring that so that we can build something that really works? Most people never say, please God, let me get to the nursing home, right? They want to go, they want to live and die where they age in the same place really till the end. I won't say any more. I'll just leave you with the slides, other than that COVID exposed a lot of very tough realities in long-term care that have been well known for more than 20 years. And one issue is that much of the care, 90% in most places, is delivered by well-intended support workers who are often, almost always women, racialized, underpaid, cobbling together multiple jobs to try to get a full-time salary. And COVID has just revealed so much of this sort of nasty underbelly of how we don't value old people and don't fund it. The people who are in long-term care institutional settings now would have been in hospitals 20 years ago, full stop. So you need to fund them like hospitals were funded 20 years ago. Lots of professional staff around, or more at least, more people overall, more professional education in the setting, clinical direction and so on. You just we cannot afford to continue this system where we simply lock people up and sort of give them duct tape and some string and hope they can manage to care for 100 old folks with 3 or 4 staff who are the least formally educated. This is not anything bad about them, but the least formally educated in any team dealing with these very complicated, complex patients. I would urge you, and I hope you'll join us, to think about how we will reimagine aging in our country. Think about where long-term care takes place. I just mentioned that. And how will we help people stay at home as long as possible? Think about drones delivering things. Think about driverless cars. How will you, as a new generation of nurses, the best educated ever, as I said, new ideas, how can you help us to think about how to turn the healthcare system on its head so that we can make this kind of progress moving forward? I'll close with just a couple of comments reminding that it is the year of the nurse, and we have seen the unbelievable sacrifice, hard work, courage, and value of nurses around the world. And I am unbelievably proud to welcome you into a profession that I never thought I'd go into, and have been an RN. I've been working in healthcare for 42 years, and I think 38, I'd have to count it now, I think 38 of those as an RN. An unbelievable career. It's unbelievable. So this moment in time, which is going to be difficult, excuse me, your transition into COVID settings and masks and PPE and arguments about safety and so on, is a blip. It's a very huge blip, but it's a blip, and it will end at some point. And we need you and want you to really step forward with us and help us as we talk with governments and so on around what healthcare can be and what it can look like. What's all your new knowledge that I don't have? You've got lots of knowledge I don't have. How can we bring that to bear in healthcare systems? Going forward, I hope you will join your professional associations. I certainly hope you'll join CNA. We have great relationships with governments. We have an Academy of Nursing with a novice leader stream in it and emerging leaders, and we need and want your support. We have so much we can learn, and this sounds like a very pat thing. Young people are the future, blah blah. You hear that all the time. I believe it, that we need to engage deeply with the well-educated people coming into the healthcare system before we sort of get you into the grind where sometimes people just fall in line. We need people who won't fall in line and will continue to challenge and help us move things forward. The public trust of nurses is higher than any other profession. And the new poll that that's in Canada and in the United States for 20 years, the new poll that came out in Forbes magazine just this week showed that nurses were somewhere around 85%. And the next group down was more than 20 or 25% lower than that. Like, it was a huge gap. In Canada, it's been a bit narrower, but nurses are always at the top, except the occasional year when firefighters go there. So I would urge you to never forget what a powerful, powerful resource that is in your pocket. There's not a single person in society that wouldn't like to say, they trust me more than they trust you. They will look to me for information, knowledge, and leadership. And I'll tell you, nursing colleagues, the public expects us to do that, not just talk about it, but actually do it. And that's the kind of work we're going to need you to do on top of all the busy work that you're going to have to do delivering care. And I'll close just by, I say this to almost any group, we need really courageous, and it's hard. Sometimes your lip is going to quiver and you're going to feel like you're going to cry because it's tough to fight these things sometimes. Active, disruptive people to improve outcomes and systems. Otherwise, they're just going to always be the same. And you're young, many of you. Some are coming into the career older, but still young in the career. You don't want to be miserable for the next 40 years. You want to be in vibrant systems. We have to build them. I want to thank you for making the time to listen to this talk. I realize it was a bit all over, but I wanted you to know some of the work we're doing, some of the concerns we have at the national level as we look across the country, and the places where we're going to need help. We need you with us. I hope you will join the effort, and I certainly hope that you get a great amount of support out of the Nursing the Future initiative. And I want to thank you, Judy, so much for all the incredible work you've done on this. Thanks so much for including me in the program. Bye-bye.